Anyway, Dr. Bob, this is for you. The interesting thing is that we're going to go ahead and just start like we normally do. Take a look down here, see what I've got. Legs are even. Looks good. Legs are even. Looks good. And hips look good there. All right, so I'm going to come in here. Let's see if that's moving. And there's actually, his SI joints are clear. So guess what? Doesn't really matter. All right, so what we're going to do is he typically has an EX-IN combination. His EX is typically on the right, okay? So I bring this in through here, that opens up, and then this here's his IN. Now, the IN feels tighter, which doesn't make a whole lot of sense. All right, Tyler, so what we're going to do is we're going to have you flip over bacon, all right? So we're going to focus on his hips now, Amy. All right, not his head, all that hair. All right, so what I'm going to do now is I'm going to see what other motion components are in there. He's a little tight right in through here. Alrighty, we'll see what this one's doing here, and he's not as tight on this one here. Alrighty, so what I'm going to do is I'm going to bump the pelvis, not the pelvis, but the femur head here, just a little bump, and then that there will open that up. Alright, and then we're going to take this one over here. This one here being more severe. So there's a little pubic component on this, so I'm going to punch you in the crotch a little bit, bub. All right, relax, relax, relax. And I felt that release in the knee. Did you feel that too?
Yeah.
All right, so flip on over, lay on your belly now. Okay. So now what we're going to do, extend that out, extend that out. All right, now the interesting thing in this is now he acts more like the EX-IN that we talked about after we went ahead and cleared out that trochanter, or the angry little hip sockets. So now I'm going to come back in here, and there's that motion, and then there's that motion. Does that feel fairly even to you, bud?
No.
What are you feeling?
It's like more on the right.
Feeling that on the right? All right, so let's take a look here and see what else is in here. He was stickier on the one side. Let's take that out. How's that feel now?
That's good.
Okay. And how about, relax it. How's that feel there now?
It's still tight.
It's changed. There we go.
Oh.
So what do you feel? More muscle in there?
Yeah, it's like more tension.
Uh-huh. So, let me double check this here through this plane. And then we'll take a look at this through this plane. Much easier on this plane right here. You feel that? All right, so that's where the AS comes from. So listen, maybe I don't have all that out of there. So let's take this, bump this, and see what I've got there. Now, come back in here, bend it, bend it. How's that feel now?
It's like tight at like the hamstring.
All right, so,
Ugh.
So now what we're going to do is come in here. Now the interesting thing is as I go in through here, is he looked relatively benign and easy. But it's getting into the weeds.
Oh, man.
Okay, relax it. Let it go, relax it. Uh-huh. Relax it. How's that feel in there?
The left still feels a lot better.
It feels better on the left?
Yep.
Well, so feel the difference there
Yeah.
and there?
Mm-hmm.
So what you can see is that I had to go in there, I had to flip him over because he had reversed presentations. Again, this side was an EX. Typically, that sticks on that side. The IN typically opens up on this side. It was the opposite when we started. So I got in there and I moved the trochanters around, if you will, or the femur heads, and plus bumped the pubic bone just a little bit. Brought them back over, discovered that even though these joints were moving, they weren't moving correctly. So I had to go back in, go through the process, also take out the trigger points on the posterior aspect of the knees to go ahead and finish them up. Now all the tensions is gone or are gone now.
Yeah.
And so his body's now functioning at a higher level than what it was, which is what we're after to begin with. So I don't know if that confused you or not, but the thing is we had to listen to the patient and find out exactly what was going on in spite of what we were finding. So it's complicated, not that complicated, but you definitely have to do your work. So anyway, I'm going to go ahead and go on up, and then I've got another patient, and we'll see if that one's a little easier for us than he was, okay? My head doesn't have to be in it. Are you going? All right, so firstly, go ahead and get in here, see if there's any knots in there. Go ahead and roll back in through here, see what her leg length looks like. Wouldn't you know, I'd get the only two people that actually are coming in here and their SI joints are looking halfway decent until I dig a little deeper. That one's moving. That one's a little sticky right there. All right, so what I'm going to do is I'm going to start off with that left. I already know I'm going to hit the trocan knees in there. So, what is she? She is a right EX, just like her brother was. All right, a little catchy there. And then there's the IN. Now, she's doing like she's supposed to. Looking at her brother right now. I don't know if you can see my head or not, but I'm looking at him. All right? So, anyway, go ahead and come right in through here, Amy, so Dr. Bob can see this. All right, so she's a little sticky over here, but you see how she opens up here, and I come over here, and it's sticky here. This is an EX. Basically what that means is this is opened up. This is stuck. It's not going to open up anymore. So I can go ahead and pull this way. It's not going to open anymore. It's stuck. So it's going to take the whole pelvis with it. This one here is flat, right? So I come in through here, it'll open up. Now you can feel she's got tension in through there, obviously. So we're going to go ahead. Oh, another thing. Typically flat here, typically munched up here. Okay? All right, so we're going to go ahead and get in there, and I'm going to work on both sides. I'm going to close this side down while I'm opening this side, all right? I probably should do it the way that I show you in the book, though. Hang on a sec. All right, let's do this. I'm going to take this here. I'm going to stabilize on the sacrum, which is posterior. So the sacrum's posterior here, right? It also at the same time is right inferior. So it's posterior and tilted down like this, okay? So what I'm going to do is I'm going to go ahead and close it up, drop this down, so I have some place to go. I've got to open the space, right? So that's the IN, or basically the pelvis doing this, alrighty? So, gotcha. All right, now, see what I've got there, and see what I've got there. Still a little catchy there. So now what I'm going to do, and I'll show you based upon what's in the book, I'll close this side down, and I'm going to open this side and plus stabilize it. You feel that clunk? I felt that in her knee and her ankle, both. So that EX really needed to go. Still catchy in there. Let's see what else you got. Take that, take that. That right knee still got a little catch to it. So, write that down as well. Now there's no short leg here. Okay? What I'm doing is I'm just going based upon motion. Alright, so what I'm going to do here now is I'm actually going to close down the EX. I'm going to keep it closed, but I've got to take the PI, right? So I've got to take this and move the PI in here. Just like so. It's a little bit more of an advanced movement. Feel the difference in that? Big change. Alright, so now, floppy, floppy. Feel the difference in that? Alright, so, we'll bump the trochs. That'll lighten up the tension on the psoas, right? And, I'll take this here. She got a knot in the back of this knee here. Nice job. I'm going to get that knot out of there. I know, that feels awesome. Trigger point on both sides there. Alright, going to double bump, get that tibia moved back a little bit. There you go. Alright, so come in through here, there's like hardly any tension in here whatsoever. So that's a winner for us. So body right rotation. I'll take this, rotate. Remember, if there's a curve in there, typically the curve will go ahead and swing along the same size as the body right. So the spinous is like this and rotates this way. Typically there would be a curve there, short leg, whatever the case is, right? So typically, but again, why I take x-rays is that in some cases, and more often than not, that curvature, because of its compensation, can actually go the other direction. There you go. And there's the right. So this is why I always tell folks, let's get, goes the other way, let's get a set of x-rays. That way, there is no guessing. So, take that in there. Little kick clunk. Kick clunk. There you go. And I'm going right through the joint plane in through there. Let's do nose to your right. There you go. Take that in there. And pull this back. Good, in center. And then let's go ahead and go nose to the left. And there's a TL there. You just go ahead and roll that body right. And then nose in the center. Good job. Ta-da! And that little sucker right there. Get the rest of the scalenes out of there. Right leg up. High as you can for me. Got it, Owen? Got it. Okay. Feel okay in there? Okay, Dr. Bob. There's some information for you. Sorry it took so long to get to you. Anyway, any questions? Give me a shout, okay? She's over here. Shut up, dog. So what we're doing is just tractioning the space. There it goes. You feel that capitate?